for the hour. Okay, so let's go ahead and do that PowerPoint. So cognitive impairment, like I said, it has to do with not being able to think. And we do find it sometimes at birth, they can't lift their head up, right? Or they're not grasping. All of those things tell you something's going on. And that might be an early intervention, or it might be something that'll be an ongoing intervention. So when we talk about cognitive development, there are things that we look at as we get older, trying to figure out what's going on. So some impairments could be their IQs are low. They can't, they don't have that thought process and that thinking to put it together. I mean, most of our cognitive development delays we're going to see when they're younger. We're not going to see them when they're older. It could be with communication, not being able to live by themselves, that they're, academic school, what sort of school are they in? All of these things that you would see. Now, how do we take and reclassify cognitive impairment? Well, there's mildly, and then there is moderately. So if you're mildly impaired, you think of cognitive impairment, think of the Downs child, right? They do have some delays. You have autistic children. Some are educatable, some are trainable, some are not. It just depends on, the child and what they're able to do and how early intervention was started on them. So 85% of the population is educatable. We can teach them. They can go to school, they can learn. And then there's some that don't have that learning capability, but they're trainable. I've got this one great guy at the grocery store, and he bags my groceries for me. And he does a great job. And I always tell him how I always make sure I'm in his lane, and I always try to give him $2. I said, no, go get yourself a soda. And he's like, I can't do that. I said, no, but you can have a soda. And he does take it from me. So there are levels, as I said, mild, moderate, severe, and profound. Now that severe is only 5% of the population. And this child who grows up to be an adult is going to have a lot of supervision to keep them safe. They can't live alone. They need someone there, a guardian at all time. And then there's profound, which is that one that only 1% of the population. Now, what causes cognitive impairment? Well, we know there's chromosomal, right? We know there's chromosome 18, 21, 15, 13, 11, and 9. Those are all Downs. They're all different numbers for it. It could be from just pregnancy that there was an infection. Something happened and it did affect the brain. What about trauma? We have these children that, intrautero, something happens, maybe in a car accident, there was, bounce the belly, it could hurt that brain and cause it. It could be at birth. At birth, we're giving vaginal deliveries to many of our babies. We're pulling on that head. Sometimes we're using suction to get that baby out. So that thing can cause it. Or it could be postnatal. The child is born, and, as I said, we always are going to strap these kids in because these kids do move and they wiggle and they turn over and they do fall, and they can fall on their heads, especially the younger children. So we have to be, careful of that because brain injury could be caused from that. Metabolic endocrine disorders, all of that there's some children born with metabolic conditions that need certain formulas because of that. So that's why we do that PKU test, take the little blood out of the heel, those little circles when they're born. That's part of it there that we'd be looking at it. As I have said since the beginning of class, inadequate nutrition. Nutrition. You don't have it, there's no fuel for the brain, and you're going to have delays. And if it goes on too long, you may not ever catch up. So catching it quick is what we want to do. All those meningitis, encephalitis, all of those. Chromosome, as I said, prematurity and low birth weight, or even post-mature. We don't think about it, but children born at low birth weight or premature, their brains and their vessels in their heads are very fragile. And sometimes even just knocking the crib, a loud noise, can cause them to have brain bleeds, or called interventricular hemorrhages, which are from level 1 to 4. And with that brain being filled with blood, it can cause some delays. Some it's just hyperactivity, some it's autism. There's many different levels of that. And we don't know who's going to be what, because as I said, children are all different. There are psychiatric disorders that can cause that. And of course, environment. Is there chemicals in the environment, or, radiation, all of those things. So, how do we as nurses take care of these children with impaired cognitive function? Well, as I've said from the very beginning, if we can get early intervention done, these children can come a long, long way. There was this little boy, Johnny, who was at the daycare where I was doing clinicals. This little kid is Down's autistic. It's amazing how that child, because he's been with this program since birth almost, that he knew to come in, take his backpack off, put it in a cubby, and sit down and wait. And then the nurse would take the vital signs, and then he knew could get up to play. He was taught, he was educatable. And to be Downs and autistic, that was quite amazing. But why? Early intervention. We tried to teach these children how to take care of themselves. Try to potty train them, teach them how to dress, how to feed themselves. Try to give them the best that they can possibly be. And we know play is how we exercise with children. So getting the muscles and the brain moving with thinking about playing and how to get there and what do I want to do with those toys. Now, how do we have children? How do we get them to communicate with us? Some children are nonverbal. Jonathan, my CP child, he nonverbal, didn't talk, but he would see me across the room and smile so big because he knew I was going to give him a hug. And he had communication. He had a little pad that he had gotten from the March of Dimes, and he knew how to talk to us through that. So he had a method of communication. Some of it, it's pointing, hearing, mimicking sounds, or even have those little boards where they could point to things that they do need. Just because a kid is low or impaired in cognitive function doesn't mean they don't need discipline. They do. They need to be told right and wrong, and to do the same thing. It's what you call routine and consistency. They need to be around other children. As they get older, they're going to need some information on sexuality. They need to know what is a right touch, a wrong touch, because they really don't know. And especially when you talk cognitively impaired, and then you got an adolescent boy or girl, they could be taken advantage of, right? So we really need to let them know that right and wrong touch. And families, remember, it's not just us, not just OT, PT, speech. It is a whole family that's going to help this child be the best they can be. So help them and get them ready for the future. Because remember, children who are babies grow up. Many of them do, right? So what are we going to do when maybe mom and dad are too old, or cannot take care of them anymore? So being ready for those plans, something that you don't think about, but it's something with these children that you must. And taking care of them in the hospital. Cognitively delayed children really want mom or dad to stay with them. It keeps that comfort level. And without mom or dad who really knows what they're saying or what they're expressing, they're the people who know them the most. So if they're not in the hospital, these children can get very aggressive and very upset. So we encourage parents to stay then. How do we prevent some of this cognitive impairment? Well, of course, yes. No smoking, no alcohol, no drugs, when you're pregnant. Making sure you're taking that folic acid, right? Before you become pregnant. Sometimes that's hard because we don't always know that we're getting pregnant, but as soon as we know it. Being aware of our surroundings, our environment, Rubella, making sure we're immunized because rubella can cause birth defects. And then if there's any sort of history in the family, we need to do genetic counseling. If the parents really want to know if there's a possibility of some sort of genetic problems like Downs. So talking about Downs is the most common of all chromosomal abnormalities. As I said, there's a lot of different Downs, 21, 18, 15, 11, and 9. And the smaller the number, the more cognitive delay that they are. The one that I saw that was the most, all the things that were going on that could affect Down's children was a 9. And that child was born with a hypoplastic heart, was born, couldn't breathe without a ventilator. The hands were deformed, the feet were deformed, and the kid had to be at home care on a ventilator. He lived for about 1 year. Now, what is a big thing that happens with Downs and we always look for? It's a cardiac condition, usually a VSD or an AV canal. It could be one of those. And it's something that when they're born, we do look for that, especially in Downs children. We know that increased maternal age, does increase the risk of Downs. Now, what does a little Downs child look like? I think they're the cutest, sweetest, most lovable children. When I was a teenager, I used to teach swimming at the YMCA and taught these children. And it was such a pleasure to gain their trust and having them dive into the pool. Or I swim on my back and they touch my hands and they would kick and go into the deep end. And that's a big deal for them, where they would only wanted to be where they could touch. Now, if they have those big round faces, they've got oval slanted eyes, they have a flat bridge of a nose, a protruding tongue, and they're hypotonic, which means their legs can both go over their head. You got to be careful with them doing that because sometimes their hips pop out. That's how flexible, they can be. That flat nasal bridge in their nose tends to lead them to have a lot of upper respiratory infections. It gets clogged there and it sits there and creates bacteria and it causes them to cough with all that nasal mucus, okay? If they're Downs, we're going to be doing an analysis, to see what number they are. And then we know how to take care of them more for intervention. As I said, congenital heart, they'll always be looking for. They're also prone to hypothyroidism and leukemia. So they will be checking thyroid levels at least yearly on these children to be sure. And then, of course, any signs of leukemia, we'll be checking for that. So that's a beautiful picture, tells you all of the things, what they look like. They've got the creamy creases and hypotonic, and I absolutely love them. So what do we do for these children? Well, if they have a cardiac condition, we're going to fix it. If there's things that we need to fix, we'll correct. Well, of course, we'll be looking at hearing, their sight, their thyroid function, like I said, and then making sure that they have the therapies they need in order to get them to be the best child they can be. I mean, many Downs are children that can be trainable and educatable. She was the in-service educator for this facility, and her sister had a Downs child who went to college. She went to Brown University, one course at a time, but somebody followed the child. It was a new program they were starting. So I think that's amazing that we give every child that chance to do those sort of things. Now, Fragile X. Fragile X is very similar to Downs. It's the second most common of all genetics, but these children, they have still, they've got all those cognitive delays, but there's more features. They have a big, large head, they have big ears, they have big testicles. They also have hyperactivity and aggressive behaviors. So autistic, aggressive behaviors, and Downs type things with delays. So these children are placed on medicine. Downs, no. These children need it to keep them calm because they do get very aggressive, even with early intervention programs, and they can live a normal lifetime. So again, this would be a child that you would help the mother and father prepare for long term, right? Now, hearing impairment. We at birth now do check all infants for hearing, making sure that they do hear before they leave the hospital. But sometimes we're going to have some children that don't hear. Why? What happens? Well, sometimes they're not born with an ear. Sometimes there's no connection to the inner ear. Sometimes it's that prematurity and maybe interventricular hemorrhage, and it stops the hearing process in the brain, or ototoxic drugs. All of the SINs, the vancomycin, the aminoglucosides, they all, if they're given the doses, we watch them with peak and troughs because it causes ototoxicity and renal toxicity, which means hearing loss, and that can cause it. Another thing we found, not only with hearing, but with eyesight, is O2 administration. I mean, it used to be, remember, I've been a nurse a long time. I've seen a lot of changes. Used to be a kid start to desat, a baby. We would just turn that oxygen up on the machine. And we found it was burning their eyeballs and causing hearing problems. So today, we turn it up a little, give a couple extra breaths. And it's a change in practice, but we're saving, the hearing and the eyesight of these children. One of the big things in hearing impairment is chronic ear infections, and especially if they're not treated completely. So that kid with chronic ear infections may have hearing loss, and these children need to be retested for their hearing if they're one of those type of child. At birth, if there was any asphyxia or hypoxic episode, that can cause also hearing problems. Infections and cerebral palsy is another one. So there's different types of hearing impairment. The conductive, that means it doesn't go to the inner ear. We have sensorineural, which is the inner ear now doesn't work. So you have it can go through, but there's no communication. And also there's a conductive sensorineural loss, and they don't get the sound in there. They don't hear it. So how do we do hearing and measure it? Well, they just put these sounds in the ears and we see if the child's moving their head towards it. And it's done, by speech pathologists. Well, why is hearing with speech? Well, think about it. If you can't hear, how do you know what you're saying? Your speech is going to be garbled. So one of the things that you're going to think about, you have a child who doesn't speak well. First thing before we do anything, I mean, of course, look at the ears infection thing, but the first thing we're going to do is we're going to do a hearing test. Are they hearing? Because if they can't hear, they're not going to be able to speak that well. We have all sorts of medical and surgical interventions. Maybe it's antibiotics, maybe it's antihistamines, stuff to try to clear out those canals to make them hear better. We know there's hearing aids, and then it gets more sophisticated into those cochlear implants. I was down at the University of Miami ENT department, bad sinuses I've had for years. And there was a kid in the next room, must have been like 3 years old. And they put the cochlear implant on, like I've seen on Facebook, these kids, saying, Mama, now they can hear themselves. Well, I heard it from the room over. And I was like, oh my gosh, I got tears in my eyes. And I said to my husband, listen, that kid just started to hear for the first time. And I think that's neat that we have that ability to do that today. Can you imagine not hearing mommy's voice? Can you imagine that? I can't. All right, what would you see in an infant that didn't hear? Well, you walk in your room, you smack your hands, they don't move. Okay? Loud noises, they don't move. And you will see them, it's what we call the lack of startle reflex, right? And then they don't turn their head. Infants hear noises, they turn their head to you. They're not doing that, something's wrong. And again, we test brand new neonates before they're 28 days old, before they go home, we're going to be testing for their hearing. Many times this is a little girl who has her little implant in there, and they can turn up the volume so that they can hear. So that's a pretty neat thing. So, child with hearing impairment, what are you going to do when they're in the hospital? Well, you don't know if they hear you, right? So you need to be looking at them, talking to them. Maybe you have a picture board, you have something to help explain, and you don't have to yell because they don't hear anyway. Just slow, easy conversation and asking them, do you understand? And they will tell you as they go along. I've mentioned child life before. Child life is newer. It's in the last 15 years that I've seen it. These people are taught how to play with children on their developmental level, and they have bachelor's, master's, and doctorate levels. So they're very well educated. And they come in and they speak to these children, let them touch, feel the equipment, and get them, to understand. And this is a person you would call if let's say this kid's going to open heart surgery, right? And they can't hear, making sure that they do know what's going on. Preventive measures of hearing impairment, well, make sure they're not premature, right? That could be part of it. And that could be good prenatal care. That treatment and management of those ear infections, otitis media, and then making sure the infection went away after you finish that dose of that antibiotic. Genetic testing could be part of it. And of course, those ototoxic drugs when they're, younger, because those drugs can, hurt the ears, of course, and the kidneys. And then prenatal care, ruling out syphilis, rubella, or that ABO incompatibility, knowing I'm positive, daddy's negative, that blood's going to fight at birth. And then, of course, avoidance to exposure to noise pollution. This weekend I went to one of my nephew's wedding, and there's babies there, and all of them had little headphones on because the music in there, this DJ was really loud, but they had the headphones on. It made me feel better because I know that noise could have hurt them. Now, visual impairment. I mean, I can't see close. I can see far away. This is absolutely common in all children. Children, can be, what we call partially sighted, which means glasses. And then, of course, there is legally blind. The thing with this is if they are a visual impairment, we need to do things or have extra large print for them, especially if they're at that point where they can still read. We know we can do a test, the Snellen chart, 20 feet away, one at a time. And if you are seeing at 20 feet what others sees at 100 feet, it's going to be 2100. And these children, we need to tell the doctors so we can get them some glasses. Myopia, near sightedness, which means I can't see far. And hyperopia, farsightedness, means I can't see near. Why do they put those things opposite those names? I don't know, but it is. Why did they do that, right? Strabismus is where the eyes cross over and they sort of trying to focus and they're really not. So they cross over midline. Amblyopia is a lazy eye. Now, how do we treat amblyopia? This eye is lazy. Cover the good eye, let the lazy eye work, and you put a patch on it, like that little girl in that other picture. Make that eye, that muscle work, and you take it off and on several times a day, and it makes it work. And they're usually correct. Trauma. I mean, kids are always sticking something in their eyes. That's why if they have straws in their drinks and they put their heads down, sometimes that, or falling down, running into pine trees, all of that stuff. Now, what do we do when a child has a trauma? Well, If there's a little floating something in there, you can take a tissue to take it out. But if it's stuck in there, something like a pine needle or something, you're going to put a Fox Shield, a hard eye patch on both eyes, and they need to go either to a pediatric emergency room or a pediatric ophthalmologist, and they need to take care of it. Because remember, there's liquid inside of our eyes, right? We don't want to make this child blind forever. So whatever we do with an eye with injury, we don't want to make it worse. What causes visual impairments? Well, those prenatal, postnatal infections, of course, any of them can cause it. Now, retinopathy of the premature is from oxygen, where we burn the eyeballs, the retinas. And there is corrective surgery to do, but this child will always have some sort of visual impairment. Again, trauma can cause it, postnatal infections, and then if there's anything that has to do sickle cell, juvenile rheumatoid arthritis, Tay-Sachs, has to do with the clogging of the vessels in there, and it could cause visual impairment. Now, you think of eyes and eyes infections, you think of conjunctivitis, right? Kids are always getting stuff in their eyes and getting goopy eyes, as we call it, right? So how do we treat it? Well, most of the time it's just cleaning that goop out with just soap, just water, with just a tissue, a rag, warm, and get it out of the way. And then there's ophthalmic ointments and ophthalmic solution. Now, remember, if you're putting ophthalmic ointment in there, the eye's going to get blurry, right? And we don't want them to think, oh my God, I can't see, because the medicine's in there. We usually, with children, will only use that at nighttime. Now, the liquid is easier to put it in. Just pull down the little sack and just put it in, and it'll be fine. Sometimes we've got to be careful, whether it's eye ointments, anything, infection, giving steroids, because remember, steroids make us immunosuppressed. So it can exacerbate anything. And infection control. Nurses, wear your gloves. Make sure immediately after you take the gloves off, wash your hands again, because it is very contagious. And then, of course, teach the family and that child, wash the hands. Another thing as a nurse, what I would do, I tell them every morning, change the pillowcase. Because what have they done all night long? And it's something that they reinfect themselves. So how do we do a nursing assessment? Well, we're going to see, children who they were premature, they were on long-term, the aminoglucoside, vancomycin, which caused that ototoxicity. We're going to check them to make sure, can they see well? A lot of times you'll see these children bumping into things, and they should be beyond that, and we'll see that. In an infant, they're not looking at you, or the eyes trying to focus and get into the place to look, right? Because your eyes just cross midline. As they get older, we'll do the Snellen test on them. And we're also, if you ever see a child that pupils don't react to light, this is an emergency concern, and this is something you should tell a physician. Now, sometimes children are born and they're blind. And the one thing is, children, babies can see mom and dad, and they need to be put in the parent's arms as soon as we can and try to do that parent-child attachment, because they can't see them. They have to smell them. They have to feel them, right? Those are your other senses that we do use. Now, visually impaired children, they're amazing. They can get around their houses, well, as long as we're not moving the furniture around. So they know how to get around. They can use a cane or not, whatever. In the hospital, they don't know our environment, right? So this child, I would walk around the room so they know where their stuff is. And many of the rooms have bathrooms in it if they're admitted. So showing them where stuff is. And then making sure everybody who goes in there doesn't move the furniture, right? move the bedside table somewhere else, and the kid just, knocks it over, right? And that kid would get very upset. So we want them to be independent. We want them to do as much as they can, but we need to keep them safe. So preventive, again, it's that prenatal care, rubella, safety for eye injuries, and of course, we're going to be checking that hearing visual impairment. We know that if they can't hear, they can't see, there's going to be delays. So we need to encourage some sort of intervention to help them keep up with children that's with a normal hearing and the visual. You're going to see these kids finger spelling, mouth speaking, all different things to get their points across. And what is that goal for that child? Some of them teach them Braille or hearing people, how to lip read. All of these things, whatever they need to do, can be taught early. Now, one condition that can happen to the eye is called a retinoblastoma. You see that white? It used to be when you took a camera with flash, your eyes would both get white, right? Well, it's not like that today. So if we get a picture with that white there, that is an eye that has a retinoblastoma. Now, the youngest I've seen was an 8-month-old little girl, and one eye was white. It is the most common of all interocular type tumors, but it's usually younger children that you see it at. And you'll see that what we call cat's eye. And what does that mean? Well, you go to your back porch or out your back window. Let's say there's a field back there. There's a deer, there's a rabbit, there is a cat, a dog, and you see the light shine in their eyes and you see that white stuff. Well, that's called a cat's eye. It's when you shine white. So that would be the first step in checking it out. It requires the whole eye to be removed, and they put a false eye in there. Yes, they'll end up with one eye in the end, but the outcomes are good with this, but they'll have one eye. Now, autism. Autism, we don't really know all why, how, when it happens, but we do know it is what we call, it affects their voice. It's very, they don't have a big language. They do these repetitive, restrictive behavior patterns. Well, I've mentioned my little Downs autistic boy, right? He was clearly, this was like, tells him what he did daily on a daily basis. For instance, he'd have a stool and he'd take the fire truck, put it on the stool. Then he would take a doll and put it on the fire truck. And then he would take a ball and put it in the back of the fire truck. Then he would take the ball out, he would take the doll out, and they put the fire truck down. And then he put the fire truck back up, the doll in, the ball in, repeat, repeat, repeat forever until you stop them. It's that repetitive behaviors. It's more boys, mostly boys, this occurs to. And we usually do not diagnose these till they're about 2 years old. Now, many years ago, there was a physician who published an article that said that the varicella vaccine causes autism. And why did that doctor say that? Well, when do we give the varicella vaccine? About 1.5, maybe 2 if you're a little bit delayed, right? So they blamed it on that. Well, they've gone back, looked at the study, it's false. That physician no longer has a license. So autism is not caused by immunizations. That's the end of the story. But it created havoc, and it's a preventable disease. Have you ever had varicella? I mean, you're sick, you don't feel good, and you've got that rash that itches all over you. So autism, as I said, is caused from a lot of different things. We don't know, and we're guessing a lot of it. It's a genetic disorder, has to do with brain development, could be immune, it could be environmental, and it could be that one child had autism, there's going to be another child. If they're male, they're going to have it. They have a really hard time socializing with other people. Their language is going to be very delayed. They only might have a one word at 2 years old. Their behavior is aggressive. They don't follow rules unless there's early intervention that's got them into this routine. These kids need a routine. They do not like you looking in their eyes, and they don't want you to touch them. So it's a hard child to work with. And then you put him in a room with a lot of other children. Then you put on a, let's say something everybody's going to sing and clap. Most autistic children would not like that. So it's a child that if we suspect, and sometimes we can at an early age, get them into that early intervention, and it does help. So prognosis, many children can, through education and early intervention, get to a point where they can improve and they could be more social and more lovable. There is no cure. We don't even know why it occurs, right? We can improve them, their ability to express themselves through language or other means. So again, recognizing it early, try that behavior modification, again, not accepting bad behavior, and then structured routines. Well, when you have one child in the house who's autistic, it is a family disease or something that the families need to all work with. And the little brothers and sisters and older brothers and sisters also need to be a part of this. I've seen parents feel like they did something wrong, and it's something I always tell them, it's nothing you did wrong, but what you're doing now for your child is the best. And that's all we can do is to support them, because these children also, we can have good outcomes. But again, it takes a lot from those parents. And there are a lot of resources out there. Some families put them in long-term placements and some family keep them at home. But today, most parents keep them at home and get them to the therapies they do need. So going off of that, the nurse is discussing sexuality with the parents of an adolescent girl with moderate cognitive impairment. What should the nurse consider when working with this? Remember, cognitive impairment, we're talking adolescents. Which one? What did I tell you about these children? They are abused. They're used because of their lack of knowledge. They don't know good
The
and
answer be
bad.
C.
Absolutely. Thank you, Ashley. Yes, they need a well-defined concrete code of conduct because these children are abused, these adolescents and young adults. All right, let's go into chapter 38, separation anxiety. What is separation anxiety? Well, can every parent stay with the child at all times in the hospital all the time? They need to go home and shower, go home, get new clothes, especially if you're a single parent, right? You have to work or you have another child. There's things you've got to go. And these children, especially your younger ones and cognitively delayed ones, that they don't tolerate it well. So they go through what we call 3 stages of separation anxiety. First of all is protest. They're crying and crying, I want mommy, I want mommy. They're not letting them walk out the door. Once they leave, they continue to cry. And it's called the protest phase. Despair phase is they stop crying and they just sit there quietly and don't know what to do. When they get to the detachment stage, this is where they don't even care if mommy comes in again because it's been so long that they've been there, or so they think. They go into a detachment. The thing with detachment is children need to know that they're loved by their parents. So This is a time where you need to, when the parents are able to be there, that you have them do as much as they can with the child. And let that parent know that the kid probably saying, Mommy, go home. Maybe then their nurses are being so good, and Mommy, go home. And we still want to keep that closeness, that attachment with the parents. So there's 3 stages. Early childhood, we know we don't want them to be separated if at all possible. When it gets to be that late childhood, adolescence, who's more important is their best friends, it's their buddies, it's their peers. That's who they want there. Okay. But if the peers can't be there, then, Mommy, all right, we'll take them as a second, but they more want themselves. These children, especially the older children, in the childhood, they don't now have control. They don't know how to express themselves. They don't know what's coming on. So, and then we're doing all of these things, going in, doing vital signs and blood pressure. And it doesn't seem like a lot to you, but for a kid it is. So they get overwhelmed. The effects of hospitalization start before, during, and after. Doesn't matter. They are afraid to go in, they're afraid to stay there. And then when they get home, they're still afraid because they like post-traumatic stress syndrome. So trying to decrease that a lot with keeping parents there will help. We know children with difficult temperaments are going to be more difficult, especially if they're in a hospital and mom or dad can't control their child for whatever reason, right? Usually it's up to 5 years old and male that create more of a problem and more stressor on this hospitalization. And the kid who's in the hospital a lot could be your sickle celler, right? In and out for many different reasons, might have had a bad experience. So that's the child who might have more problems dealing with the present hospitalization. So today, we are curing, we are doing things to prolong life in every single way. I mean, it used to be cardiac children, only, 80% lived through, let's say, the hypoplastic heart. Well, today we're up to 98%. So we have really, and that's just one area, we are really having children survive through things that, years ago that they didn't. But what does that do? You have children with special needs going home because we fixed them where years ago they wouldn't have. And your hospitalizations are longer. And now these children have gone through so much. So now they're going to also be with the hospital, be afraid with it. But remember, these children at home are going to have more things the parents or an incoming taking them to whatever therapy. Now, the difference of going into the hospital, there's urgent cares, there's outpatient type procedures that we do. Now, being admitted to a hospital, we know that they are going to get everything they need, whether maybe they're getting the IV antibiotics instead of PO antibiotics, so they're going to recover a lot better. And we know that hospitalization is good, but we also know we have to make sure that that child is safe and comfortable with it. We know kids get into the hospital and all of a sudden we come in and we're in control, right? We have to do this, that, and the other thing. You're going to have some parents ask you, how long have you been a nurse? And what is your degree? And how long have you worked here? And they're going to be going, have you ever seen a baby like mine? And that's normal. They want to make sure that you're the best your child can be. And this is pediatrics. That's part of pediatrics dealing with a family, right? And just be open and honest as best you can, right? And if you don't know an answer to a question, say, I really don't know, but let me go ask so I give you the correct answer. And you know something? That's what they want to hear. What about brother and sister at home? They're scared. They're worried. Their brother, their sister's at home, right? So let them send in a card, or thank God we have FaceTime today, right? or those things. I mean, um, keeping them involved. I used to send home coloring books to them and stuff with little crayons that the hospital had to keep them involved with it. Getting them prepared. What are they going to see? So this boy, he's still smiling. He's seeing his little brother there, and he's okay because he was told what is the baby going to look like. And it's good for both of them because the baby's missing his brother and the brother's missing his baby brother, right? So that's what we need to do. And it does help. So getting a kid ready for a hospital is hard. When should we do it? Well, not too much before they're going to go, but give them a little time to be prepared because we know that their biggest fear is that separation from mom and dad. I go in the hospital, are you staying with me? Right? So we're going to try to keep that as minimal as possible. Keep them on the same routines, whether it's bath time, whether it's feeding times, and whatever they're eating. Sometimes they're there a long time, put a schedule up, the older kids, and they can read it and know what's going on. Again, children, as I said, keep their routine and keep them understanding, that you're there to help them and be honest the way you do stuff with them. A lot of times, pediatric hospitals, like the Child Life, the playroom, that bottom left-hand picture is a picture of my hospital. There's a playroom that when they're non-infectious, they can go up and color and make things. Could be someone with a long-term hospitalization due to whatever reason. And that's called diversional activities. Sometimes they can't go there, so we're going to bring toys to them, things for them to do in their rooms, keep them occupied. Video games we have crayons, we have TVs, movies, Disney, whatever, toys, whatever it is, bring it home. And we know that having their own pajama or their own pillow, whatever, all that stuff helps. So, and now there's the family, right? So, as I've always said, as you're sitting there talking to the child, doing something, make sure that you are doing it in a manner where the child understands and the parents listening, and then encourage the parents to participate. If you're on a floor, you could have 6, 8 patients. Having a parent watch your child to keep them safe, I would teach the parent, this is what I want you to look for. If you see it, come get me. They are your biggest ears, your biggest eyes, and it will help you take care of the child in the best way. And when you're doing that, you're teaching them, getting them ready to go home, right? And then you're finding out, what do they need to do? I mean, let's say they need a dressing change. I would do it the first time, and then I would watch them do it with me. There's no reason why a parent can't do that because you're going to do it at home. Now, ambulatory, outpatient, it's in and out. That means they go in for maybe ears, tubes put in, and home. It is less stress. They don't have to stay there. They're with mommy. Parents now walk them into the OR today and knocked out. When they wake up, they call the parents to come in recovery. They feel that reduces the stress. We know they're not in a hospital, so infection is decreased, the cost is decreased, and we get those procedures done quickly. Sometimes isolation is needed. For instance, if you had chickenpox and you went to the hospital, you have to be in an isolation room. So that can create stress on it. So again, give that child all of the stimulation they need, making sure that they have things to do when they're in these rooms because they can't be walking around the halls. Emergency rooms. That bottom left-hand picture was a nurse I worked with, and that guy was an EMT who worked on the trauma team. Used to go on the copters and pick up children. And emergency rooms are stressful, especially what if you come in on a copter, a kid, and then there's the parents following behind. They're just stressed out. So remember to take care of those parents. I would always get social worker and patient rep there to help me take care of these children. And then intensive care. Intensive care is daunting. You might see all of these monitors, all these noises, all these machines, and again, making sure we're meeting the needs of the family too, because it's scary to see that. So during the first 4 days of hospitalization, Eric at 18 months cries inconsolably when his parents left, and he refuses the staff attention. Now the nurse noticed that he appears to be settled in, unconcerned about seeing his parents. The nurse should interpret of what? This is separation anxiety, right? It's one of those 3 stages. It's detachment. He's adjusted. Well, he had to, right? He didn't transfer any trust. Nope, they don't do that. He's not at home, but it's that third part. Now, pediatric variations, things that are different. Remember, 18-year-old children sign their own consent if they're cognitively aware, okay? And parents need that child's permission to understand. We have emancipated minors. Sometimes we have people there. Sometimes it's telephone consent. Two people have to get it. Or if it's an emergency, a physician's going to do that. Getting ready children for procedures, again, get that on their level, developmental level, and let them know and touch and feel the toys. Show them on a doll what's going on, and that's going to help them be ready and I'm going to be talking as they're with the doll and doing the things that you said it's going to do, and you're allowing them to express their feelings. They're going to do a lot better. As I said, pre-op, parents are going to be there. Post, sometimes there's sedation. You see that little white syringe behind the mother there? That's propofol. That kid's about to knock out, but the mother's right there. So when she goes to sleep, she'll remember, mommy was there with me, and that's going to help. Post-operative, we know we have to watch for certain sort of things that could go wrong. We're going to be monitoring them on a monitor or a sat monitor, doing vital signs, managing the pain, right? Using those FACES FLAC numeric scales, making sure that they're deep breathing and coughing. Again, teaching, discharge instructions. So remember, there's one thing that we don't think about is you send a child home, you've done all of this teaching. Were the parents and the child compliant? Did they do what they're supposed to do? As in, did they tell the doctor when they saw some oozy come out of a surgical wound? Did they make the appointments? Sometimes it gets to the point where it goes to pill counts. Could be narcotics, or seeing, did they take their antibiotics? Skincare, general hygiene. Children do end up sometimes being in the hospital, in a bed for long periods of time because they're extremely ill. So we need to maintain the healthy skin, turning, positioning, making sure that they get no reddened areas, using a draw sheet to move them so no shear injuries going on. Again, feeding them and then keeping their fevers down. Because remember, fevers are not going to hurt them, but a fever, actually a fever who stays up really high and it's not responsive to, let's say, acetaminophen, probably virus. Viral infections have the highest fevers and are harder to control. But if we can get it down, that child's going to feel better. So we're still going to continue to do that. Always be careful with safety. Always tell the parents about it. It could be even the straps off of curtains, blinds. I've seen them wrapped around and strangulate them. In between the recliner chairs, I've seen them get their head snapped in that recliner, the bottom part, because they're always climbing, right? And we know toys, and I've talked about falls from here to there all the time. They're always, especially your toddlers, the dive bomb kids. And infection control, always. Use universal precautions if you don't know. And if you're ever in doubt, put a mask on. It's not going to hurt. Transporting children, usually it's in their beds, in their isolates. Um, these are all fine, and we do that. Older kids, we got straps, and we put them in those little wagons, and then they feel it's fun. And of course, I'm going down the hall going beep 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 beep, and the kids are laughing as we go because then it's fun. Restraining. Do the least amount of restraining that you have to on a child. Restraints today need number one, a physician's order to get a restraint. And number two, you have to check it every hour to make sure that these restraints aren't causing a decrease in circulation of the arms or the feet or whatever. Now, we should do things like alternative methods, that diversion, whether it's blowing bubbles and over here with somebody, or the TV, or giving them a sticker, whatever that is. And it's the thing I developed for our hospital system. Huggies help us give great injections efficiently and safely. H period, U period. And that's therapeutic holding. That means mommy hug me while I'm getting this stuff done so that we can do it that way. And then again, restraints as minimal as possible that we can, because we don't want them to be strapped down and that's all that they can think about. Positioning, make sure that we position them properly. As we get into those routines, we'll be looking at it. Again, safety, like I've already just mentioned all that. And infection control, take care of yourself. Now, heel sticks on infants. How do we do them? Well, you take a hospital-approved warmer, put it on the heel. There is a special lancet that we use that says infant, and we're going to prick that side of that little foot, and we're going to be very slowly put the leg down, and then we're going to squeeze it very gently. We don't want to bruise that heel. We do mostly on the infants, if it's for an infection, a catheterized specimen. It's the most accurate. But if you just need a routine urine, we can go ahead and we can do bags. And then if they need a stool, if we have it, or we could do swabs, of course, blood. We know how to do that. Usually it's a pinch with a peripheral stick, and then of course, any respiratory. Giving medicines, you shouldn't put it in food or milk. And if it's with a baby, take a syringe to the side of the mouth. And again, if you put it in the mouth and the kid's not swallowing, have the parent take a deep breath in and blow real hard in the face, and they'll swallow it for you. Again, making sure you use the proper sites, the proper size needles on these children. And then you'll get into all of the central things. One of the things we use a lot in pediatrics, especially for chronic kids like chemo, is this bottom left one. That's a Huber needle. It's called a port. The other one is a Broviac, but it's intermittent. We can take it out when they're not there. G-tubes are used. Make sure that we flush them before and after. And kids do really well with them. Just make sure we don't pour it in too quickly. Rectal administration works pretty quick. A lot of times we'll use that for the acetaminophen suppository. It works good, but sometimes it doesn't stay in, so you have to be careful with that. ND tubes, NG tubes, OG tubes, all for oral feedings, and TPN. We use that a lot for kids that are NPO that needs all those vitamins. And if they go home on it, we're going to be teaching it. So eyes and ears, we know we blow the nose first, we give it in the nose. If it's in the ear, make sure you do it, pull the ear up and down the right way so that you're getting it. Intake output, important. So how would you weigh your diaper? As I've said, if you have a diaper that weighs 30 grams and it's now wet and you're weighing it and it's 60, it'll be 30 milliliters of urine. And we can collect a specimen by putting a little cotton ball in there, and the cotton ball will collect it. Fluids, we know we need to secure it. Well, sometimes they're really hard. The one thing about O2 therapy, that little plastic hood is the easiest tolerated on infants. They can look around and still suck their fingers and have their little pacifier. And they will have an O2 sat probe. Make sure you change it because it can burn. We do have intubation and tracheostomies, again, just like adults, but they're smaller sizes. We're going to get into asthma and aerosol, feedings, tubes. We're almost over time, so I'm going through this. Enemas are given. Kids do get constipated. As I said, it's one thing that they can control. So it's a little tiny one, and we can get them. So preferred site for IM injection on an infant, which one?
D.
Vastus lateralis. Yes, we made it. Thank you, guys. Try to talk really quick. It was a lot of information. Now, that variations of nursing and pediatrics, it's an important chapter. A lot of differences. It's differences of adults versus children. So it's something that you just go back and do review it, okay? Any questions? I'll be giving your grades out on Saturday by 2 o'clock, and I'll send you a message and post them as soon as I can. Okay, I'm sorry it's taking so long. I have no control. I used to be able to give a but I was told no. So I tried, but I can't do it anymore. So I apologize. I sure wish I could, because I would. You guys have a great day. Thank you so much. Thanks for your patience early or the other class. And I'll see you next week. Cardiac respiratory, rough week. I'm going to send you some matchings. You're going to like them.
Thank you.